Module number 5 of Milestones in Algology will discuss some ethical considerations related to the present treatment of pain, as well as describing the concept of torture by omission. I believe it is appropriate to begin this module by reflecting on some comments by the ethicist Ben Rich.
One of the root causes of undertreated pain is the apparent belief on the part of clinicians that the treatment of pain should be based upon a different set of principles and practices than any other type of patient care. There is at least a superficial irony in the proposition that patients whose moderate to severe pain is time-limited by a terminal prognosis should be offered whatever level of opioid analgesia is necessary to relieve their pain, while patients with the same level of pain that could persist for years must receive suboptimal pain and symptom management for their own good. The latter group would seem to be more deserving of aggressive therapy than the former.
Professor Rich comment that chronic pain patients are being treated by clinicians who use principles which are different from those used for the treatment of any other diseases, suggested that there is a stigma associated with being a chronic pain patient. This is clearly the case, and I must bring to focus this troublesome reality, especially as this stigma has become more evident during the last 15 years and continues to become even more accentuated. A chronic pain patient is the only patient suffering from a devastating chronic disease who is asked to sign a contract for therapy and being warned that the failure to follow the specified rules could result in the denial of effective medical care. The comments of Ben Rich in an article in which he discusses this issue are interesting, especially for a person like me who has no legal expertise. I understand his opinion to be that the pain contract has no legal standing, as a contract implies negotiation between the parties involved. In a pain contract, there is no negotiations. The patient is asked to sign the contract under duress, because if the contract is not signed, the physicians will not treat the patient. There is no question that patients treated with dangerous drugs should be fully educated on the therapy that they are being prescribed and on the benefits and risks associated with their use. It is well known that this is most effectively done with a written document explaining the treatment modalities, the goals, as well as the proper use of the medication prescribed. Therefore, a written document should be given to each patient being treated for pain, especially if opioids are prescribed. But it does not require a signature and should not be used as a threat. The drug screening test should not be required of every patient taking opioids for several reasons. The most important are the realizations by the patients that the reciprocal trust between physicians and patient is broken, the added cost of the test, and the frequent misinterpretations of the test that can give serious consequences for the patients, including being fired by the physicians and having difficulties in finding another physician to treat his severe pain. About 10 years ago, several pain specialists asked that an easy-to-use electronic prescription monitoring system be developed to help in the treatment of difficult patients, especially to identify patients who receive controlled substances from many different doctors at the same time. However, it was never intended for this system to be open to free, easy scrutiny to law enforcement agency. Pain is the only disease that is denied the protections of physicians-patients' confidentiality. All the above-mentioned requirements mandated by many states when a physician is treating a chronic pain patient with opioids have caused a chilling effect to the point that many physicians refuse to treat chronic pain patients. This is in clear contrast with the Institute of Medicine report that 40% of all physician visits are prompted by pain. Another recent interesting statistic begs some reflections. The National Institute of Health has reported in 2014 that 14 to 19% of all patients taking opioids abuse them. This same statistics implies that 81 to 86% of patients taking opioids use this medication properly. Yet, many states now mandates that all patients using opioids for legitimate medical treatment be considered abuser, as these states require draconian oversight on all patients treated with opioids. At this point, one person may ask the questions: what will be the accepted way of treating pain patients requiring the use of opioids? The patient should be verbally instructed and provided with the written documents that educates the patients about the treatment modalities and the benefits and risks associated with the treatment prescribed. Only if the physician has concern of abuse and diversion, more stringent oversight should be mandated. This would require that the physician first queries the electronic prescription monitoring database. Second, that the physician uses the urine drug testing, which, however, would require the physicians to be properly trained in ordering and interpreting the test. And finally, third, any suspicions or concerns of drug abuse should prompt a referral to an addictologist and pain specialist who will closely collaborate in providing proper medical care and other therapies for the two diseases which are afflicting these particular patients. Furthermore, to protect physician-patient's confidentiality, the access of law enforcement agency to the electronic prescriptions monitoring system to obtain information on an individual patient or physician should require the permission of a magistrate. Law enforcement agency as well as research institutions can have easy access to the generalized statistics that do not disclose the identities of an individual patients and physicians. These changes could reassure the great majority of physicians that the treatment of pain patients does not expose them to particular scrutiny by state and federal agency, and allowed them to fulfill the mandate of the Institute of Medicine report that said effective pain management is a moral imperative, a professional responsibility, and the duty of a healthcare professional. Earlier, I have described the difficulties associated with the assessment of pain, which is based on a subjective report and which is often minimized by physicians. It is interesting to read or listen to reports of pain experienced by physicians. In 1975, Dr. David Freed wrote a letter to the editor of the journal Lancet, in which he describes the pain after a surgical procedure and how difficult it was, especially at night, to deal with the poorly treated pain. He wrote, "Let no one fall into the belief that he or she can measure someone else's pain. Dr. Philip Pizzo is Dean Emeritus of the Stanford University Medical School and was the co-chair of the Institute of Medicine Committee, which published in 2011 the report entitled Relieving Pain in America. In 2014, Dr. Pizzo delivered the Maria Luisa Ferrari Lectureship for Life, entitled Chronic Pain, Overcoming a Public Health Challenge. As part of his lecture, he recalled his personal experience with severe pain, in particularly on the impact of severe pain on his daily life and his understanding of the depressive effect that chronic, persistent, severe pain can have. In 1987, John Bonica, during the symposium celebrating his 70th birthday, delivered his autobiographical lecture entitled Wrestling with Pain. In the lecture, he reflects on his severe, persistent pain and that it made him realize and understand the impact that severe pain can have on the patient's life and mental status. It is very interesting that both of these accomplished physicians state that they can understand, based on their personal experience, why some people would consider committing suicide when faced with severe, unrelenting pain.
Got to a point by fall that I couldn't sit, stand, or walk or lie down for more than 10 minutes at a time without having absolutely riveting, severe pain. Now, you can imagine the conversion, right, of going from healthy to impaired, completely impaired, and yet still having to have a facade of functioning. I was still, after all, leading a medical school and having to do all the attendant duties, and it was enormously challenging to do that. And as time went by and procedures were done, 4 MR scans, 4 different injections, none of which really made a difference. By the time I got to the end of the year, I called my primary care physician and said, I think I'm really becoming clinically depressed. I think I need to go from the medications that I'm on to some kind of antidepressant. My whole mood had changed. This speaks to the question that I raised earlier of which comes first, the pain or the depression. And the clinical depression never became so profound that it moved to the point of becoming, if you will, suicidal. But I well understood how that could happen, how people could engage in chronic pain and begin to move into a very significant depression because your whole life is turned upside down.
Obviously, chronic pain has no biological function at all, but is a malefic force which imposes extremely serious physiological and psychological and emotional impact. I can tell you, I've had times when I tried to tough it out, and I said to myself, I know why people commit suicide because of pain. So I think it's very important for those of you who have not experienced pain to keep remembering that it's an unusual experience, particularly persistent pain. For 1 year, for example, I had no hip joint, and every time I flexed my thigh, the top part of the femur would hit the scar because they had to remove an infected prosthesis. And they waited a whole year to be sure there was still aseptic. And it was constant, every step was painful step. It has caused me to have a great deal of appreciation of what Milton said. Pain is perfect misery, the worst of all evils, and when excessive, it turns all patience, and I can tell you it does. So, ladies and gentlemen, I was convinced by my colleagues to tell you the story. And I hope that this just has given you some perspective, and I would like to implore you to work even harder in order to help people with pain, because it is a terrible, more terrible than death. That's what Schweitzer said. So.
Albert Schweitzer was a true Renaissance man, a musician, a missionary, a surgeon, a philosopher, a philanthropist, and a Peace Nobel laureate. He is often quoted for these two concepts that he wrote in a book. He said, "We all must die, but if I can save him from days of torture, that is what I feel, my great and ever new privilege." He also said that pain is a more terrible lord on mankind than even death itself. These quotes are from a small book titled On the Edge of the Primeval Forest that he wrote in 1924. In the book, he describes his experience as a missionary physician in a small African village. These reflections were prompted by a recurrent event. Usually, an elderly man would start to complain of abdominal pain that in the following 3 to 4 days would become progressively severe, associated with agitation, until the patient, screaming and extremely restless on the floor of the hut, would die. He found that this man had developed an incarcerated hernia, which would cause bowel obstructions, followed by bowel perforations, peritonitis, and excruciating pain and death. Being a surgeon and having built a small hospital in the village, he was able with the simple operations to reduce the hernia and prevent the agonizing death for the patients. Let us reflect on a specific word that he used. The word is torture. Torture most often consists in inflicting severe physical pain, either for punishment or to obtain information from a reluctant enemy. Fortunately, this cruel custom is forbidden in true civilized countries, but unfortunately there are still many countries in the world that engage in this barbaric activity. However, torture was quite common in the previous century. It was so common that it was included in artworks like plays and operas. In Giacomo Puccini's opera Tosca, there is a torture scene. In the second act, the chief of police, Scarpia, to obtain information from his prisoner, the painter Mario Cavaradossi, subjects him to be tortured until Cavaradossi's lover, Tosca, provides the desired informations. Well, this certainly must not be allowed. But there are situations, even today, in all civilized countries, in which what I call torture by omission still exists. My definitions for torture by omission is that when we know how to control severe pain and we do not do it, we are subjecting an individual to unnecessary severe pain, not much different from active torture. Let us consider labor pain. It is estimated that 80% of women experience severe pain during the delivery of a baby. Now, it is the woman's undeniable right to undergo natural childbirth. But if a parturient has asked to receive labor analgesia, it is torture by omissions to allow these situations to occur. These women's screams, unfortunately, are not heard by our society because the masses of patients suffering severe pain do not scream together and in unison, and each patient's scream is lost in the cacophony of everyday noises. Torture by omissions will not be defeated until all the involved parties, mostly the patients and their family, unite in a common endeavor like the HIV and AIDS movement in the 80s. They must convince all the responsible organizations involved in education, research, and medical coverage that this never-ending suffering must end. The Italian writer Primo Levi clearly stated what are our responsibility. He wrote, "If we know that severe pain and suffering can be alleviated and we do nothing about it, we ourselves are tormentors or torturers." I strongly believe that we should always remember the mandate of the Institute of Medicine that emphatically stated, effective pain management is a moral imperative, a professional responsibility, and the duty of the people in the healing professions. I hope that I have convinced you that the reduction of severe pain to a tolerable level, it is a human right. These concepts concludes module number 5. Module number 6 of Milestone in Algology will describe basic concept of pain therapy, including multidisciplinary and interdisciplinary approaches, as well as the use of multimodal therapies, including non-pharmacological modalities, and the use of non-steroidal anti-inflammatory medication, acetaminophen, anticonvulsant, and antidepressive medications.